Well, welcome to our talk today. We're going to be discussing hormone replacement therapy and updates regarding hormone replacement therapy. And I'm Dr. Molly Force. I'm the clinical director here at Prosper. And joining me today, we've got Dr. Rosalie and Dr. Mary. Our clinic here in Port Townsend is very much focused on natural medicine solutions. And we like to see ourselves as primary care physicians who really integrate the evidence-based medicine regarding natural options for people for health solutions, as well as balancing with clinical blood work and other specialty tests to help us understand what's going on for our patients. So one of the things that we've started doing this year is providing these clinical spotlights to our doc talks. And the reason we've shifted to doing this is we have so many interesting questions that are coming up from patients that we really want to provide the most recent information possible. And specifically today, as we're going to be talking about HRT and more specifically bioidentical BHRT, we're going to be updating some of our clinical uses of BHRT and helping you guys understand some of the latest and greatest information that's come out about this and how we've really applied that to our clinical practice and how we can understand what that means for you in regards to safety and the longevity of this type of medicine used in your healthcare. So today we're really hoping to talk about what BHRT is. Now, many of you might be very well versed in BHRT, so we're going to give a nice little overview. And while we do that, we're going to really try to spotlight some of the forms of HRT or BHRT that we use most frequently in our practice and why we find them to be so beneficial. And we're going to also be providing those wonderful updates about what we can do to help with symptom management, specifically for menopausal transition or perimenopausal time periods, and what we can do to help prevent degeneration and disease with HRT and BHRT. And of course, we get a lot of questions about the safety, so we're going to dive right into the literature about that with you as well. So when we're thinking about bioidentical hormone replacement, these are medicines that are plant-derived typically. Now, they're synthesized down to be biochemically identical to the hormones that you're creating already in your body. Now, this is a really wonderful thing for us because we want those chemical structures to match perfectly what our body is making, because that affects the receptor sites and how those chemicals come in and dock up and send signals to your body. So we've got two major forms of hormone replacement therapy that are offered. We've got these compounded bioidentical hormones that are made specifically for the patient, and the levels of those compounded hormones are individualized with each prescription that's written out. And then we also have the more conventional HRT therapy, hormone replacement therapy, where oftentimes we're using a synthetic hormonal derivative that will trigger those hormone receptors, but may also have some other unintended consequences as those hormones are being ingested into the body. So there are major benefits for our practice in using compounded hormones. We get less additives in the products, and then we have a much higher control over the dosing. That means we can really individualize if a patient needs more estrogen or more progesterone, or maybe they need more DHEA or testosterone. We can really dial that up or down depending on what's appropriate for our patient. A good example of this in regards to our bioidentical versus conventional medicine is when we think about progesterone, and we're going to talk about this more, but we will be going into the different types of progesterone, and we have something called prometrium versus the compounded micronized progesterone. And both of these are actually bioidentical technically. So there are some pharmaceutical HRT that are bioidentical, but the difference between the prometrium and the micronized progesterone that's compounded is that the prometrium is going to contain a peanut oil, and it's sold in these very set quantities. So you can get them in like 100 milligrams and 200 milligrams, but not the in-between dosing. So for our patients that might need 125 or a specific milligram amount to get them to that physiologic balance, that's a lot harder to do with some of these set HRT hormones. When we're thinking about the bioidentical hormones, we have to be thinking about our estrogens as well. Now, there's three main forms that are provided as bioidenticals. There's E1, estrione, E2, estradiol, and E3. And you'll see that there's a little asterisk there next to the E2 and the E3. Now, these are the forms that we're using clinically at Prosper most commonly. We very rarely prescribe E1. Now, there are some practices that will prescribe E1, and the reason that we've chosen to prescribe the E2 and the E3 is that we find them to be safer when we're looking at clinical data. We know that E2 is our most potent form of estrogen for the body, and E3 is considered a little more protective. It's also a little less biologically active. So it's not quite as strong as the E2, but by providing both the E2 and the E3 at the same time, which you can do in these compounded creams, we're able to use less E2. Now, the reason we're interested in that is that E2 can theoretically convert back to E1, and E1 is the more concerning form of estrogen that we get a little bit more interested in having reduced, because that's the one that can be more concerning in regards to some of our risks for cancers. Now, there are animal-derived bioidentical hormones. So it's not all just the plant-derived that we were talking about for the compounded. The example of that is these equine, so horse-derived estrogens like the Premarin. And we have also, there are some combinations of estrogens that are extracted from these mares' urine. So there are also synthetic, of course, hormones that are non-bioidentical, and those we're generally in our practice trying to step away from because of some of the side effect risks of those. I'm going to turn this over to Dr. Rosalie, who's going to go over testing.
Thanks, Dr. Molly. So, when we think about how to test hormones, there are so many ways to do it, and different clinics, different physicians will have their preference, whether they test through the blood, the urine, or the saliva. As you can imagine, as Dr. Molly mentioned, with the horse urine being a way to extract the estrogens, we see a lot of hormones in urine. This is a chart that I often refer to with patients in office, just to talk through which is the best testing modality. And the answer is, it depends. The one that we typically use here, it has the asterisk next to it. It's the salivary testing. But there are other ways, there are other reasons to use the blood or the urine testing. The salivary testing I find to be most accurate for the ways that we prescribe hormone replacement here, which is most typically a topical application of the estrogens. So when you're applying topical estrogens, that cream, the medicine has to go through the skin and then be absorbed in the bloodstream and then sort of taken up in the tissues. And so you can imagine all of the tissues of the body sort of take up this cream, and we end up testing the saliva because the tissues of the mouth have taken it up, right? And then we sort of know ultimately what is the bioavailability of the treatment with the cream. When we just check the blood, it's more of a spot test that tells us what is your hormone level right now in the blood. It doesn't tell us too much about whether the tissues are actually taking it up. The tissues we're most interested in when it comes to menopausal symptoms are the vaginal tissues and the other mucous membranes. Since in menopause, those typically dry out fairly quickly for a lot of women. So when we test the saliva, it's also a way to test those mucous membranes. So this is a really interesting reference slide to look back on. And like I said, different clinics have their favorite methods, and the reason why we do this salivary testing is because it shows us a lot more ultimately. So what are some symptoms that hormone replacement therapy can help with? It's not just plain old menopause, I'm having hot flashes, right? There's so many other symptoms here that we end up using a gentle physiologic dose of hormone replacement therapy to help with those symptoms. So what I love about this slide is just the percentages here at the end of the sentences that say, okay, when you're going through menopause, what percentage of women are experiencing the following symptoms? So vasomotor symptoms being a huge one, feeling suddenly hot, suddenly cold, night sweats or hot flashes. 80% of women will experience this for a variable amount of time. Maybe it's just a year, maybe it's 10 years, right? Sleep disturbances as well, especially insomnia, all the way up to maybe 75% of women experience this in menopause. Pelvic floor changes, when the tissues are drying out from the dip in estrogen, you get some urinary incontinence, difficulty holding in the urine with a sneeze, for example, a diminished libido. Up to 50% of women have this symptom. Cognitive changes are another big one. Brain fog, forgetfulness, trouble with word finding. Almost up to 50% of women as well have this symptom. Mood changes, whether it's irritability, anxiety, depression, this is also a big one. And then a whole other category of weight gain, headaches, uptick in migraines, hair changes, muscle joints, pain and stiffness, right? There are so many symptoms associated with menopause that ends up being one patient's experience compared to another. It's very individualized what that transition looks like. But HRT is something that can sort of help ease the transition. When we think about menopause and the diminishing levels of hormones, there's also an uptick in other diseases. Other systems of the body will respond to that dip in hormones, whether it's hypertension or high blood pressure. We start to see an uptick in our menopausal patients. Cardiovascular disease as well, since estrogen I think that's supposed to say estrogen diminishes insulin sensitivity and prevents adequate glucose regulation, which leads us to the next bullet point here, which is hyperlipidemia, also blood sugar dysregulation. Osteoporosis is a really big one too, that we start to see estrogen is really protective for the bone. And we'll talk through some data here in the further slides on how HRT can help osteoporosis specifically. And then arthritis as well. What's pretty amazing is that 30% of collagen, which is the building block for the joints, is lost within those first 5 years of menopause. So collagen is what keeps the tissues elastic, whether it's the vaginal tissues, the skin, you name it. So HRT can also help smooth out that loss of collagen. And then dementias. This is a growing field of hormone menopause-related dementias that we start to see those go hand in hand sometimes. 20% of women get some sort of form of dementia after 45 years old, which is sort of our perimenopausal years, which is sort of a wild statistic to think about. So to treat symptoms, there's some really good research here that we'll be diving into. The first one being HRT as its use in hot flashes. So estrogen alone or combined estrogen with progesterone therapy decreases hot flashes by about 75% in a recent randomized controlled trial. That's amazing, right? Talk about trying a treatment and seeing a pretty immediate effect. So that's really, really great data to have in the back of our pockets. And then with sleep, again, both estrogen and progesterone together have shown an improvement in sleep quality. I often will dose progesterone at night for its really wonderful effect of helping patients fall asleep. Yeah, next slide. Another 3 bullet points here on the research that we looked at for vaginal dryness and pain, specifically pain with intercourse. Estrogen therapy is the most effective for improving vaginal symptoms of menopause. And I've seen this be used both at topically on the skin, but also intravaginally in suppository form. And that's where sort of the low dose vulvovaginal applications, meaning the suppository form of an E2 or an E3, will improve symptoms without actually needing to do a systemic dose of HRT. This is a really wonderful place to do some symptom management without needing to do a full HRT protocol. Urinary incontinence and pelvic floor prolapse. Again, low dose vaginal estrogen promotes collagen synthesis. So when we have our collagen on board, our tissues are a lot more elastic and can hold things in a lot better. It helps with treating pelvic floor prolapse. That says it's unclear. And I know Dr. Mary will actually touch on this in the later slides as well. And then I always use, when I'm using HRT for urinary incontinence, I'm always using it in combination with some pelvic floor programs, whether it's a really tense pelvic floor or a more relaxed pelvic floor. Both can lead to that symptom of incontinence. And lastly, this is a really big one I see in my elderly patients, my elderly women specifically, is postmenopausal vaginal infections, just recurrence of UTIs. Since estrogen promotes the establishment of lactobacilli in the vaginal vault, which is really key for a healthy vaginal microbiome, and more specifically, what's known as the estrobolome, which is a pretty fun word that means kind of the estrogen supportive microbiome of the genitourinary tract. I'll hand it over to Dr. Mary here.
Thank you, Dr. Rosalie. So that was just an overview of some of the main benefits that we use HRT for. And one of the biggest questions that I get from patients and that, we see in news headlines is HRT safe? And this is a very complex question, but we did our best to lay out all of the research here. And so bear with me, I'm going to walk you through a lot of research, and we're going to really draw out the main points and main themes that we see throughout different studies. So prior to 2002, when this the Women's Health Initiative hormone therapy trials were completed and they started analyzing the data, there was a general sense that that estrogen and progesterone therapy were generally safe when it came to breast cancer and cardiovascular, meaning like stroke and heart attack risk. And but they decided to do this massive study that had over 27,000 participants in it, and they were enrolled in centers across the United States. And what they wanted to assess was, is estrogen and progesterone effective in preventing cardiovascular disease and breast cancer? So this was a really interesting question, because it wasn't, are they effective in treating the symptoms that Dr. Rosalie was just talking about? They're asking, is this helpful for preventing these major events like breast cancer and cardiovascular disease? And so what they did was they administered oral equine estrogens. That's a type of estrogen that is extracted from mare or horse urine. And then they also administered oral medroxyprogesterone acetate, which is a type of progesterone. It's a synthetic type of progesterone. And they administered these hormones to over 27,000 postmenopausal women over the course of 5 to 7 years. And what they saw, the trial was actually meant to go longer, but what they found was an increased risk of breast cancer and stroke risk at 5 years. Now, this was preliminary data, and they found a very small increased risk of both of these events in this study population at that point in time. And the researchers said, okay, this is answering our question that it's not preventative for these purposes. And so what happened in the medical community was it was a major turning point in terms of recommending hormone replacement therapy, because suddenly providers were really afraid because they saw, there's an increased risk of these conditions. Now, at 13 years follow-up, they were analyzing the data in a much more nuanced way, and they looked at the effects of starting these hormones at different times after menopause, and then also different forms of these hormones. So we're going to get into those details in the next few slides. And then after 18 years of follow-up, they found, there was actually no increased mortality from cardiovascular disease or breast cancer seen in the hormone replacement therapy group versus the placebo group. So just, to summarize that, basically there was a massive study and they saw a slight increase in stroke and breast cancer risk. But now let's get into the nitty-gritty and kind of dissect that more. So one of our first questions is, does hormone replacement therapy increase the risk of breast cancer? So in this Women's Health Initiative trial, they found that oral estrogen plus progesterone increased the risk of breast cancer. And this is a very small increased risk, so less than 1 in 1,000 users for over the course of 5 years. They also found that oral estrogen alone actually decreased the risk of breast cancer, which was quite surprising, I think, to most of the researchers. So the take-home message here is that estrogen and this conventional form of the progesterone, which was a synthetic form, increase the risk of breast cancer in 1 in 1,000 women after 5 years. So this is a similar risk to that would be associated with obesity and sedentary lifestyle in terms of increasing one's risk for breast cancer. And it's less than the risk that's associated with drinking 2 glasses of wine per day. And the reason why this is important is because when we're talking about some symptoms that can become debilitating, like hormone hot flashes, it's important to weigh the risks and the benefits and look at what are we really talking about when we say increased risk of breast cancer and stroke. It's important to note here that we do not pretty much ever recommend using systemic, so oral hormone replacement therapy in patients with a personal history of breast cancer. So they're found that, with oral estrogen alone, there is a decreased risk of new breast cancer cases. But if breast cancer is already available, we don't want to add estrogen to the system and potentially increase the growth of a tumor that's present. Okay, so here's another really important question. What about low-dose vaginal estrogen? Now, I really like to distinguish between systemic estrogen, so estrogen that we take at doses that are high enough to be circulating in our blood vessels, versus local forms. And when it comes to the vaginal symptoms that Dr. Rosalie was describing earlier, tissue thinning, irritation in the vaginal area, all of that, you can apply local low-dose vaginal estrogen, and there's no evidence that it increases the systemic estrogen levels, which is very helpful when we're wanting to treat someone with those symptoms, but have some concern around, say, breast cancer or cardiovascular risk. We also have seen in literature that low-dose vaginal estradiol or estriol are considered generally safe. And recently, what's been kind of shocking to a lot of providers and fascinating is that it's even considered safe in most patients who have either a history of breast cancer or actually are being treated for breast cancer, because this is common when people are receiving hormone blocking medications for breast cancer. There is an exception that you just want to talk to your doctor in that situation. So patients who are treated with aromatase inhibitors that doesn't apply to, but generally as a rule, vaginal low-dose estrogen is considered safe. Okay, so another big another risk factor that the Women's Health Initiative trial looked at was stroke risk. So what they saw was an increased risk of stroke that was seen with estrogen and progesterone therapy and estrogen alone. And this is different with different age groups. So for women who initiate under the age of 60, so under the age of 60 or within 10 years of the start of menopause, they saw an increase of 2 additional strokes per 10,000 person years of use. So that's a metric that's taking into account the years that people are using it and the number of people using it. So essentially, if it's initiated under the age of 60, it's a very small increased risk of stroke. If it's initiated 20 years past the onset of menopause, then we see a significant increase in stroke risk. So the message here is that, if you have cardiovascular risk factors, it actually makes sense to start hormone replacement therapy earlier in life if you want to consider doing it at some point. And I think that's a really important thing for our perimenopausal women to understand and kind of get ready for. And we'll talk about that a bit more later. So interestingly, a 2015 review study showed no increased risk of stroke in women who, again, initiated hormone replacement therapy within 10 years of menopause. And then we really want to look at the forms of estrogen when it comes to this question. So there they found, based on different studies using different forms of estrogen, that estradiol actually appears to be safer than the horse urine conjugated equine estrogens. And that estradiol is the one we use most commonly in our practice. And it is it's bioidentical to what we produce in our bodies. And then the other piece here is that transdermal, so patch form, or topical cream or gel form, appears to carry a drastically reduced risk of stroke than oral estradiol. So again, that's a huge preference we have in our practice to do the type of estrogen that you apply to your skin versus ingesting orally. And that's largely because of this cardiovascular risk. So we also want to look at heart disease. This is another major question that they looked at in the Women's Health Initiative trial. And again, here we saw that if hormone replacement therapy was initiated under the age of 60, they actually saw a neutral to beneficial effect on heart disease, which is, again, very interesting. So, if it's initiated 20 years after menopause, there's a clearly increased risk of heart disease. But before the age of 60 or 10 years after, within 10 years of the onset of menopause, we actually saw a potential preventative effect when it comes to heart disease. And there are a number of other studies that basically confirm that timing hypothesis, that phenomenon where they saw a decreased risk of or an actual benefit cardiovascularly when you start within that 10-year window. So the take-home messages here for cardiovascular risk and hormone replacement therapy is that if it's started under the age of 60 or within 10 years of menopause, it may actually help prevent heart disease. And when it comes to stroke risk specifically, there is an increased risk across all age groups. And that's a small increased risk across all age groups. And then again, you want to really be careful with initiating hormone replacement therapy if it's 20 years or more past menopause. It's not a complete contraindication, but it's something we really want to consider cardiovascular risk factors if that's what you're thinking about doing. And then also you really want to think about doing the transdermal or topical forms of estrogen to decrease that stroke risk as well. Okay, so this is another really fascinating point, that different forms of progesterones will have very different physiological effects and have different safety profiles. So the form that they used in the Women's Health Initiative trial, where they saw the increased risk of stroke and the increased risk of breast cancer, was a synthetic form that is less commonly used in most settings now. In our practice, we really focus on using micronized progesterone, which is mimicking the form that we produce in our body. And they found that that increased risk of breast cancer and stroke that they saw with that synthetic form of progesterone was not seen with micronized progesterone. So really important distinction there. Okay, so I might sound a little bit like a broken record, but I know that was a lot of information. So I'm just gonna give you some take-home points again that you can kind of mull over. So here we have estrogen and the conventional progestogen combo increases the risk of breast cancer in women in 1,000 women after 4 years. So you do not want to use it in patients with an active breast cancer or a history of any hormone responsive cancers. That can be, uterine cancer, breast cancer, endometrial cancer, ovarian cancer. You never use estrogens alone, and that is because we really want to protect the uterus from the overstimulation of growing the uterine lining. So you always want to have a progestogen on board whenever you have an estrogen on board. You want to aim to initiate that hormone replacement therapy under the age of 60 or within 10 years of menopause, to have the best safety profile over time. And then consider going for that micronized bioidentical form of progesterone over the synthetic progestins. And then also you want to consider the transdermal or topical estrogens to reduce the risk of stroke over time.
Thanks, Dr. Mary. That was a really deep dive into the safety of HRT, that's the big question here that gets brought up from patients all the time. Yeah, like is this okay for me? And it's very much an individualized question too. But what I love about these doc talks is, as docs, we get to sort of dive into the primary literature and talk about it all together and make sure we're all on the same page with the data. But what's pretty cool too about HRT is its use in these days as a method for disease prevention. So we talked about treating symptoms earlier, but now BHRT, there's some data coming out as its use for preventing disease. With dementia prevention, timing is of the essence. And again, you'll see this concept come up over and over again. When initiated within 5 years of menopause, HRT can be protective against Alzheimer's in women. And that's because the hippocampus, which is part of our brain that sort of stores long-term memory, declines in volume 5% each year after menopause. So adding some estrogen and progesterone therapy on board, physiologic dosing, can very much help the brain. When initiated over 65 years old, however, we do see an increased risk of dementia. Again, timing is of the essence here. We want to sort of stabilize the roller coaster that is the hormones dipping up and down in the perimenopause and early postmenopause years. Once those hormones have fully tanked in late menopause, it's hard to initiate HRT again and see all of the wonderful preventative benefits. Again, with osteoporosis prevention, timing matters. Initiation within 3 years of menopause, we see the highest benefits against bone loss. A 33% decrease in hip fracture, as well as a decreased risk of all types of fractures. And that's pretty astounding for statistically how helpful BHRT can be. So I have this conversation with my perimenopausal patients, especially if they have a strong family history of whether it be dementia, osteoporosis, or cardiovascular disease, just to talk about whether they would be candidates for this more preventative aspect of HRT. Lastly, this last bullet point talks about cardiovascular disease prevention. Again, we see a lowered risk of congestive heart disease if initiated below 60 and within 10 years of menopause. We don't see an increased risk of stroke with the topical forms of estrogen, but we do see an increased risk of venous thromboembolism or deep vein thrombosis in women who initiated HRT within 10 years of menopause. and in women who are aged younger than 60 years. So again, there's just this vascular piece that ends up being more of the individualized risk factor that we've got to look into for each patient. So again, timing is of the essence with HRT. The duration is less important. It's all about when you start. So with my perimenopausal patients, like I said earlier, HRT will smooth out those peaks and troughs of the hormonal roller coaster that is menopause. It prevents major hormone fluctuations, thus diminishes symptom severity. So the way I like to think about this is comparing it to puberty, right? That time of life where there's big highs and big lows, the emotions are big, the changes are sudden. It's sort of the same kind of experience, but at the end of a life of fertility. Smoothing out that roller coaster smooths out the symptoms, but it also helps the tissues all over the body who are responsive to hormones. It also helps them maintain their integrity instead of also having all of these shifts. There is something known as the critical window hypothesis that is new in the literature here that mentions that initiating HRT in midlife, and their average age there was 48.7 years of age, was associated with a 26% reduced risk of dementia as compared to a 48% increased risk when HRT was initiated in later life, again, more than 10 years after menopause and over 65 years old. So timing is just of the essence with HRT. So this is the big question, is BHRT right for you? Again, it's a very individualized approach, a discussion you have with your doctor or your doctors. Multiple doctors can be involved in this decision. We've got to think about timing, right? And so we've got those big cutoffs we've talked about, more than 10 years after menopause and over 65 years old. Those are cases where we end up having, we initiate HRT less frequently. It ends up being a very specific cases of difficult symptoms that we would consider. You know, the risks and benefits change at that age. And then again, what's the risk that you have personally in your personal history and in your family history, whether it's cancer risk, whether it's osteoporosis risk, and we're talking about prevention of that, dementia risk, cardiovascular disease. These are all players in this decision. And then lastly, what form is right for you? If you use the conventional route, you'll probably be given a transdermal patch of estrogen and an oral synthetic progesterone. Is that form right for you, knowing the data that we know, knowing your own personal history and family history of risk? What we end up doing in our clinic a lot is compounded creams of two types of estrogen, estradiol and estriol, and then a bioidentical oral micronized progesterone. And that combo we've sort of seen to have the therapeutic effect that we want with the safety profile with it. And again, this last point is, are we using local estrogens in the vagina, or are we using a systemic dose? All of that is a big discussion to have with your physician.
Let's chat a little bit more about how these bioidentical hormones are applied, because Dr. Rosalie and Dr. Mary went over some of this, but just to break this down for all of you. We've got the topical, which we've talked about the advantages of not having that oral systemic absorption and instead applying these hormones topically. Now, with these, we're either doing skin absorption or we're applying them vaginally. So with the skin absorption type, we've broken those down into either creams or liquids that are creamy in nature, or transdermal patches. Now, the transdermal patches can often be prescribed. You guys might know them as like Vivel-Dot. That's a really common one, but they're usually E2, which is bioidentical patches. The creams, which we're usually using one of our local compounding pharmacies in order to get, can be individualized in the quantities of what comes in those. Multiple hormones can be applied within the same cream, which can be really advantageous. So a person's not putting, 3 different applications on. And we can dial in with those compounding pharmacies exactly how much E2 or E3 we want for that patient. And that is always, once again, individualized depending on what's coming back on lab work, as far as if we're in that physiologic range, as well as what the patient's risk factors are. So these compounded creams are just fantastic. Now, we have certain little tips that we give our patients to help them absorb best and keep their dosing as low as possible, because we find with hormones, less is usually more long term. So we want to keep dosing as equalized as possible and not be going up and down and taking people on these hormonal roller coasters. And we certainly want to keep people within these, what we call physiologic ranges, which means that it's right for their physiology during their time period of life. We certainly don't want our postmenopausal women all of a sudden menstruating. That would be a big no-no for us. So with these compounded creams that we're having made, we also have the ability to provide enough E3 to be protective and to provide less of that E2, which although is bioidentical and active, it may convert over into E1, which is more concerning, like we were talking about in the beginning, of tissue associated cancers that are hormone receptive cancers. So with the vaginal creams and suppositories, that next portion of our list here, those can be sometimes purchased through different supplement companies or compounded individually. There's a period of time that we loved compounding those, for example, in coconut oil, because they were so easy for the vaginal tissues. There's also different bases that we'll use depending on what works best for the patient in these creams that we're applying vaginally. And we just see this as being life-changing for our patients, especially if they've been having or suffering recurrent UTIs because of what it does for the microbiome in the vaginal area. The other option is these orally administered BHRTs. Now, we talked about how oral administration of estrogen is not our favorite here at Prosper, but there are some forms of hormones that we do tend to like to have ingested orally. And one of those is the micronized progesterone. So we can prescribe capsules of that oral micronized progesterone. Then that will allow us to really get a good gauge of what the person needs as far as those progesterones go before we switch them over to a topical form of that progesterone. So it can be nice to have it separate from your cream when you're initiating, just to get a good idea of which estrogen or progesterone is going to work best for you, depending on the levels. Now, tablets are also available. Those are used with oral estrogens often, and that's not something we're typically engaging in here because of those risks that we just discussed. Troches are another option. We're not typically using them here, but we do manage some patients on them, and those are absorbed sublingually. So they're little sublingual hormonal pellets that people will put in. Another form that's becoming more popular is this intermuscular insertion of pellets. And these are little pellets that are compounded by a compounding pharmacy of hormones and then surgically planted into patients. It's not something that we're offering here, but it is something that's becoming more popular in the bioidentical hormone regulation world. One of the reasons we've chosen not to do that at this point at Prosper is once those hormones are inserted, the patient is left with that hormonal dosing for 90 days. And we find it to be really helpful to be able to take people off or change their dosing if appropriate, if all of a sudden someone is having symptoms from their hormonal application. And it's nice to be able to do that if they're on a topical or an oral. It's so much easier than saying, sorry, you're going to have to wait out these 90 days. So there are some supplements that are not compounded through a pharmacy that contain bioidentical hormones, and there are specific reasons why we'll use those in our practice. One of those forms of hormones, which we haven't talked much about today, is DHEA. Now, DHEA is a very important, we consider it more of an adrenal hormone that is more of an androgen style hormone, kind of grouped in closer to testosterone. Now, this we can get compounded through our compounding pharmacies, and sometimes we will, but generally it's much cheaper for the patient to do an oral capsule form through a supplement brand. So these are some examples that we use with that pure encapsulation for our patients. And there are different dosing that we use depending on what's going on with the patient's lab values for the DHEA. Now, these hydrating ovules that you'll see at the top of this slide here is made by Biswecken. We really love them as a line that makes some of these bioidentical hormones. We do recommend that patients are having testing done yearly and being tracked by their physician if they're initiating any of these. But these can be truly life-changing to have bioidenticals that are made in very gentle suppository forms. We're always paying attention to the milligram amount that's coming in with these. They definitely do affect hormone levels. So you do want to, once again, be advised by your physician with these. But we really like that they're in a cocoa butter based, and the best part is that they're pretty inexpensive, considering. So another product that Biswecken makes is Progon BL4X, and that one is one of our favorites as a topical progesterone that we'll use if we're not going to have it compounded. And what we like about that is it allows us to provide very small dosing of that progesterone in a topical form. Now, Phyto BL4X, also made by Biswecken, is another liquid form of a bioidentical hormone. This one has both E2 estradiol and E3 estriol in it, and it is based in an organic rice oil. So it's very clean as far as the product goes, and it can be a good option for some of our patients. But once again, it kind of comes down to dosing because the ratio is very set in that product as far as E2 to E3. So we always, once again, like to look at what's going on with the patient's labs and kind of make those recommendations depending on what we see. Another nod that we just wanted to give in regards to hormones that we like to incorporate in our practice is botanical medicine. We have a lot of really beautiful actors in this sphere that we can choose from in our toolbox as naturopathic physicians. So these are all physician grade lines of supplements, of nutraceuticals and herbs that are known to affect that hormonal balance. So some of our favorite include black cohosh, Vitex, which is also known as chasteberry, and ashwagandha. Ashwagandha is considered an adaptogen, as is chasteberry. Now, these can be adaptogenic that can help the adrenals as well as the pituitary and ovarian system in production of hormones. A lot of times when we're dealing with perimenopause and we're not ready to initiate bioidentical hormones, these can be a really beautiful stepping stone for patients, can help them rebalance and support that hormonal sphere in a very natural way and keep them in balance. Another product we're using, a product line that we're using, is a gelatinized organic maca product the line is known as Feminescence through Symphony. And that can be very helpful because we have a very standardized dosing of maca, which is considered to be a phytoestrogen. So we want to be careful with phytoestrogens, just like we want to be careful with our phytoprogesterones, but specifically those phytoestrogens, we do want to watch those with our patients, especially if they've got risk of cancer risk that we're concerned of in regards to their family history. But these can be beautiful bridging products for us to help with those transitions. Testaquench is another one that we'll use more for when people are producing too much of our androgen testosterone style hormones. And it's just another example of how we utilize herbs with our apothecary here at Prosper. So if you have any questions about those, please feel free to reach out to our office and we can help advise you on what would work best for you. I'm going to turn this over to Dr. Mary. Very important pelvic floor info.
Great. Thank you, Dr. Molly. So we're just going to end here with I just want to describe another modality that I use very often at Prosper called pelvic floor therapy. And this is a really amazing form of therapy for many women postmenopausally. It's very common to have changes to the pelvic floor that can arise because of these, changes that Dr. Rosalie was describing before, the pain with sex from tissue thinning and tissue irritation, and changes to that tissue collagen. So the pelvic floor is a set of it's a set of muscles that exists right below our pelvic organs in a bit of a hammock between the pelvic bones, and it provides a lot of structural support to the organs, so specifically to the bladder, rectum, vagina, and all of that that is kind of in our lower pelvis. So the health, the strength and the elasticity of the pelvic floor are both really important. When after menopause, it's really common for women to start having vaginal pain and spasm. So that can be, the lack of elasticity in the tissue starting to cause some constriction of the vaginal canal. Many people will start having urinary incontinence, and that can be due to changes in the pelvic floor musculature, as well as changes in the vaginal tissue from tissue thinning, and the urethra actually has less support around it. You can also see pain with sex, as I was mentioning, that, tissue thinning and irritation from decreased estrogen can cause some painful erosions that, often women will feel at the very entrance to their vagina. They'll feel this tearing sensation with penetration. That's one of the most common complaints that I see in the postmenopausal in my postmenopausal patients. And then one of the things that can happen with a really constricted pelvic floor is hip and gluteal pain. So that's always something I'm thinking about. So the treatments involved in pelvic floor therapy are largely myofascial release and trigger point release. So you can imagine if your trapezius is really tight and tense and you start to develop some muscle tension, it's really helpful to have that muscle massaged. And sometimes there's a point that is, really tender and causes and can cause a radiation of pain to your head and to your shoulder. That can happen in the pelvic floor as well. So it's really important to have a professional work and do body work on the pelvic floor if that's what's going on for you. And it's really amazing that, in this day and age, we have these tools to support women with, and men too. So, and then we also will often want to work with pelvic floor exercises, whether that's strengthening or relaxing, depending on what's going on. And then specifically with postmenopausal patients, the vaginal dilators can be really helpful. So those are little silicone devices that you insert at graduated sizes that will help expand the tissues when you have that constriction of the vaginal canal that will often lead to pain with sex. So lots of options and tools, and it's a good thing to keep in mind when you're navigating the hormone replacement world, that pelvic floors therapy is always an option when you're having vaginal pain and vaginal issues.
We want to invite you guys to join us again this fall for our next Doc Talk. We're going to take a little break off this summer, but we also want to invite you to check out our website. We have a very in-depth recording on hormone replacement therapy and hormonal balance recorded on our website. It's just under that education tab. So if you go there, that goes into a lot of the basics of the hormones, how they work together, and might really help you kind of flush some of that information out for you. This talk today was very much an update on things that we are really focused on in our practice in regards to how we're prescribing and how we're supporting our patients. If you have any questions for us, feel free to include them in the chat right now. We can go over those. We also want to just encourage you to reach out to our office, give us a call, or make an appointment online to have a conversation with us as a care team if you have any concerns about your hormones or want us to balance this. We truly feel at this point like very much supportive experts for people who are going through hormonal changes and people who need preventative care specifically in regards to BHRT. So we're always happy to go over that with folks.